I'm Dr. Shweta Bavari from Pharmacy Institute, Noida Institute of Engineering and Technology, Greater Noida. In this lecture, I'll be covering the topic Pathophysiology of endocrine diseases. We know about endocrine system. It is a system of glands and hormones. Okay, so when we talk about endocrine diseases, it basically occurs due to one of these four mentioned reasons. One is impaired synthesis of the hormones, impaired release of the hormones. There can be abnormal interaction of the hormone with the target tissue. There can be abnormal responses of target organs to their hormones. So these are the four common factors that result in one or the other endocrine disorders. We will begin with the first endocrine disorder in this lecture, that is diabetes mellitus. So beginning with the pathophysiology of diabetes mellitus. What is diabetes mellitus? It is a chronic heterogeneous metabolic disorder which occurs due to decreased production or reduced response of the target tissues to insulin action. Basically, when we talk about diabetes mellitus, we are talking about that either the insulin production from the beta pancreatic cells has reduced, or if the insulin production is even normal, then there is some sort of resistance or some lack in the responsiveness of the tissues, the target tissues of the insulin. The tissues or the target organs are not responding to the actions of insulin. These are the major reasons. So when basically what insulin does in our body is, when insulin is released from the beta pancreatic cells, it is released into the circulation, it reaches its target site. So when in the target site or the target cell, when insulin acts or binds to its receptor, it ultimately results in the movement of the glucose transporter. As you can see in the image, GLUT4 has been mentioned. So there are other glucose transporters like GLUT2, there are GLUT4. So these transporters, basically these are located inside the cells. Now when insulin acts on any cell, it acts on its receptor present over a target cell. It triggers the movement of these glucose transporter to the cell membrane. These glucose transporters like GLUT4 depicted in the figure, it moves to the cell membrane. Now when it reaches to the cell, this transporter when reaches to the cell membrane, it allows for the uptake of the glucose inside the cell. This is how insulin acts. It basically allows utilization of the glucose by the cells for the production of energy, for meeting energy demands. Okay, so when there is insulin deficiency or when there is deficiency of insulin actions, abnormality in the proper responses to insulin, this results in what? The glucose cannot enter inside the cell, so glucose remains in the circulation in the blood. So and it results in elevated blood glucose levels, which is known as hyperglycemia, increased glucose levels in the blood. So when we use the term hyperglycemia, so in diabetes mellitus, when the occurrence of the disease is determined by the persistent hyperglycemic state. And what is this persistent hyperglycemic state? In fasting condition, if the blood glucose levels are concentrations are approximately about or more than 126 mg per dl, or in the postprandial situations or random plasma glucose concentration is approximately or more than 200 mg per dl, and it is persistent, then a person is said to be having diabetes mellitus. Okay, when I use the term postprandial, it means after the meal. When after the meal the glucose levels are more than 200 mg per dl. When we talk about diabetes mellitus, there are two major variants of diabetes mellitus, type 1 diabetes mellitus and type 2 diabetes mellitus. Type 1 diabetes mellitus is also known as juvenile onset diabetes mellitus. Juvenile means children, right? And it is also known as insulin dependent diabetes mellitus, because this type 1 diabetes mellitus cannot be treated with the drugs. So the patients who have type 1 diabetes mellitus, they are completely dependent upon insulin injections for survival, for treatment. Type 2 diabetes mellitus is also known as non-insulin dependent diabetes mellitus, because Type 2 diabetes mellitus can be treated by the drugs like sulfonylureas, tolbutamide, glibenclamide, glycoside, and then biguanide like metformin. These type of drugs are available for the treatment of type 2 diabetes mellitus, which is non-insulin dependent type. Insulin is required only in the advanced cases of type 2 diabetes mellitus. So, as I now talking about the pathophysiology of type 1 diabetes mellitus, how this type 1 diabetes mellitus occurs. It occurs due to the autoimmune destruction of the beta cells of the pancreas by cytotoxic CD8 positive T lymphocytes that kill pancreatic islets. So, type 1 diabetes mellitus is basically the outcome of a autoimmune disorder. In this autoimmune disorder, what happens? The CD8 positive T lymphocytes, cytotoxic CD8 positive T lymphocytes are activated against the beta pancreatic cells of a person. So, when they are activated, and I am saying they are cytotoxic T lymphocytes. So, they result in destruction of the beta pancreatic cells. When beta pancreatic cells are destructed, the insulin production and secretion cannot occur. There is no production of insulin inside the patient's body. This results in type 1 diabetes mellitus. That is, the insulin production is stopped, there is no insulin production, and so the glucose utilization by the cells reduces and glucose remains in the circulation, resulting in hyperglycemic states. Then this type 1 diabetes mellitus, this autoimmune destruction may also have genetic predispositions such as human leukocyte antigen on chromosome 6 is strongly correlated with type 1 diabetes mellitus, or may be due to environmental factors such as viral infection and chemical agents. This means that human leukocyte antigen, which is a part of major histocompatibility complex that can trigger an immune response, it can trigger a T lymphocyte. It also, when this HLA is present on chromosome 6, when the genes for this HLA are present on chromosome 6, this can also trigger the immune response, which will ultimately result in beta cell destruction. Then there are various environmental factors like viral infections, various other chemical consumption of various chemical agents. They can also trigger the destruction of beta cells, and when the beta cells are destroyed, it will result in reduced insulin production and increased glucose levels in the blood, resulting in hyperglycemic state and ultimately resulting in diabetes mellitus. Now we talk about type 2 diabetes mellitus, which is non-insulin dependent diabetes mellitus, because it can be treated with the drugs that are available in the market. It is characterized by insulin resistance or derangement of insulin secretion. So, when I talk about insulin resistant, it is decreased ability of insulin to act on peripheral tissues despite normal concentrations of circulating insulin. One discriminating feature of type 2 diabetes mellitus from type 1 diabetes mellitus is that the beta pancreatic cells from which insulin is produced remain intact in type 2 diabetes mellitus. They are not destroyed. So, when they are intact, they are producing, they are synthesizing and releasing they are synthesizing the insulin in proper concentration. But if there is insulin resistance inside a patient's body, this means that no matter the normal concentrations of insulin is being produced by the beta pancreatic cells, it is unable to produce any effect in the target organs. It is not able to mobilize, it is not able to allow glucose entry into the target cells due to insulin resistance in those target organs. Okay. Then second is derangement of insulin secretion. Derangement of insulin secretion due to dysfunctional pancreatic beta cells that produce insufficient amount of insulin. That means that the beta cells are intact, they are not destroyed, but they have become dysfunctional. That is what, because they are producing either less amount of insulin, or even if they are producing a proper amount of insulin, they are unable to release it. This is what derangement of insulin secretion means. And when there is deficiency of insulin, or there is deficiency of the actions of insulin, ultimately there will be increased glucose levels in the blood, which will ultimately result in hyperglycemic states. Now we talk about the symptoms of diabetes mellitus. in both the cases of diabetes, you can see, because insulin is basically an anabolic hormone. Now, its deficiency or the deficiency of insulin action results in catabolic states in the body. When there is catabolism in the excessive catabolism in the body, it will result in weight loss. When there is weight loss, this ultimately results in polyphagia, eating disorder. There is increased hunger. Okay, so excessive weight loss ultimately results in increased hunger, polyphagia. Hyperglycemia and glycosuria, these are hallmarks of diabetes mellitus. Increased glucose levels in the blood, and when there are increased glucose levels in the blood, they will ultimately be excreted out in urine also. So, excessive excretion of glucose in urine is the hallmark of diabetes mellitus. And these hyperglycemia and glycosuria ultimately result in hyperosmolar states in the body, which ultimately results in excessive thirst, which is also known as polydipsia, and increased frequency of urination or micturition, increased frequency, which is known as polyuria. Diabetes also results in ketoacidosis. Now, what happens, because insulin fails to provide glucose, to channelize glucose inside the target cells, it fails to do so. So, glucose remains in blood only, it cannot enter the cells. So, but still energy requirements of the cells need to meet. So, there occurs the breakdown of fatty acids for utilization of the energy. This breakdown of fatty acids also results in the production of ketone bodies. So, when these ketone bodies, they start accumulating in the blood vessels in the circulation, they result in a emergency situation which is known as ketoacidosis. Then these hyperosmolar states, these hyperglycemic state, this can also result in the destruction of the nephrons, the neurons and the retina, which are termed as diabetic nephropathy, diabetic retinopathy and diabetic neuropathy respectively. Now, coming to the pathophysiology of thyroid diseases. Thyroid is a butter-shaped gland, butterfly-shaped gland located in the front of the neck just above the trachea. Thyroid basically produces two potent hormones, thyroxine T4, triiodothyronine T3. So, T4 and T3 are basically produced by the thyroid gland. These T3 and T4 influence basal metabolic process. They are involved in the basal metabolic processes which go inside the body, which occur inside the body. They are involved in the normal growth of an individual, normal brain functioning, which include intelligence, which include memory. They are involved in normal neural development. They are involved in bone development also. So, basal metabolic processes are controlled by thyroid hormones T3 and T4. The two major variants of thyroid disease are hypothyroidism and hyperthyroidism. So, as the term suggests, hypothyroidism is what? Decreased production of T3 and T4, decreased production or decreased release of T3 and T4 into the bloodstream. Hyperthyroidism is what? Increased production or increased excess production or excessive release of T3 and T4 into the bloodstream. Now, in hypothyroidism, the major clinical manifestations that occur are fatigue, lethargy, cold intolerance, slowed speech and intellectual function and reduced intellectual functions, slowed reflexes, hair loss, dry skin, weight gain and constipation. And the major clinical manifestations of hyperthyroidism are nervousness, anxiety, heart palpitations, rapid pulse, tremor, muscle weakness, weight loss with increased appetite, frequent bowel movements, increased perspiration and often thyroid gland enlargement, which we call goiter. Hypothyroidism, there are two types of hypothyroidism, primary hypothyroidism and secondary hypothyroidism. So, the most common cause of primary hypothyroidism is autoimmune thyroiditis, which is also known as Hashimoto's disease. So, autoimmune thyroiditis is an autoimmune disorder in which the CD8 positive cytotoxic T cells, they destroy the thyroid cells and result in the inflammatory state of the thyroid gland. Okay. So the thyroid inflammatory disease and iodine deficiency also interfere with the synthesis or availability of the thyroid hormone. Now, in Hashimoto's disease, when there is destruction of the thyroid cells, T3, T4 production is reduced, resulting in hypothyroidism. Similarly, if there is an inflammation of the thyroid gland, in that condition also thyroid hormone production reduces, T3, T4 production is reduced. If there is iodine deficiency, as because iodine is the major component, major part of T3 and T4, both the hormones, and if there is deficiency of iodine, then the production of T3 and T4 will drastically reduce, which will result in hypothyroidism. This is primary hypothyroidism. When we talk about secondary hypothyroidism, it is basically a central hypothyroidism. It occurs rarely in less than 1% of the cases as a result of deficiency of either thyroid releasing hormone from the hypothalamus or impaired thyroid stimulating hormone secretion from the anterior pituitary gland due to certain diseases of the hypothalamus or the anterior pituitary gland respectively. So, if the thyroid releasing hormone is not being released released from hypothalamus, if the thyroid stimulating hormone is not being released from anterior pituitary gland, so there will be no signal for the thyroid gland to start the production and release T3 and T4 into the circulation. These two hormones are required. These are the basic triggers for the production and release of T3 and T4 hormone in the thyroid gland. So, their deficiency ultimately results to the deficiency of the T3, T4 production and hence hypothyroidism. Hyperthyroidism, the most common cause of hyperthyroidism is Graves' disease, which is again an autoimmune disease. Now, what happens in Graves' disease? In this autoimmune disease, the antibodies that are produced, they mimic thyroid stimulating hormone actions. TSH actions, as I told you, TSH is produced from anterior pituitary. Now, when the TSH is produced from anterior pituitary, it goes and binds to its receptors on the thyroid gland. Okay, or more specifically thyroid follicular epithelial cells. These receptors are present where? Thyroid follicular epithelial cells. So, when TSH binds to these receptors on the thyroid gland, it then stimulates the production of T3 and T4 in the thyroid gland. Now, in this scenario, what happens in Graves' disease, which is an autoimmune disorder, the antibodies are formed which can mimic the action of TSH, thyroid stimulating hormones. So, these antibodies again and again go and bind to the TSH receptors present on the thyroid gland, and thus they stimulate the production, they increase the production of T3 and T4, resulting in enhanced production and release of T3 and T4 into the circulation. This results in hyperthyroidism. This repeated stimulation of the receptors, the TSH receptor on the thyroid gland also stimulates hypertrophy and hyperplasia of the thyroid cells, which means increase in the size of the thyroid glands also occurs, thyroid cells occur, and increase in the number of thyroid cells occur, again resulting in the condition such like goiter. Other causes of hyperthyroidism are solitary thyroid adenoma. Whenever I use the term adenoma, it means a benign tumor of a gland, and in this case it is a benign tumor of thyroid gland. Thyroiditis, which means inflammation of the thyroid gland, and very rarely a TSH secreting pituitary tumor. If there is a tumor in the anterior pituitary gland which secretes excessive amount of thyroid stimulating hormone, this thyroid stimulating hormone will go and trigger the thyroid gland to produce more and more amount of T3 and T4 and release it into the circulation, which will again result in hyperthyroidism. Moving ahead to the pathophysiology of sex hormone diseases. When we talk about sex hormones, the sex hormones are also known as reproductive hormones. So, these include estrogen and progesterone in females and testosterone in males. Estrogen and progesterone, they originate from the reproductive glands with the ovaries in females, and testosterone is produced in the testes in males. The release is regulated by hormone signals from the anterior pituitary gland in form of luteinizing hormone and follicle stimulating hormone. These two hormones, luteinizing hormone and follicle stimulating hormone, that are released from the anterior pituitary, they monitor, they regulate the release of these sex hormones from their respective glands. Now here I would like to notify that the common precursor for all these sex hormones is cholesterol, and even inside the female, the testosterons are produced first, which then get converted to estrogens by the action of the enzyme aromatase. So in female body also, the testosterons are produced first, which then get converted to the female sex hormone estrogen by the action of the enzyme aromatase. This we need to keep in mind. So moving ahead to the sex hormone disease that we will be covering in this lecture are female sex hormone disease, polycystic ovary syndrome, and male sex hormone disease, erectile dysfunction. So polycystic ovary syndrome, it is a disorder primarily characterized by signs and symptoms of androgen excess and ovulatory dysfunction in females. When I use this term androgen excess, it means that this is a disorder in a female which occurs due to excessive production of testosterone. That excessive testosterone is in circulation, and it is not completely getting converted to estrogen. As I told you, there is excessive production of testosterone in the females, and ovulatory dysfunction in females, that ovum are not being produced properly. Okay. The symptoms of PCOS or polycystic ovary syndrome include oligomenorrhea. Oligomenorrhea means irregular menstrual cycles. Amenorrhea means cessation of the menstrual cycle, or prolonged anovulatory menses means there will be periods, there will be bleeding, there will be menstrual cycle, but no ovum is released in that menstrual cycle. So prolonged bleeding states with no ovum released. Hirsutism, male-like pattern of hairs on the face and the body hair, that's hirsutism, excessive hair in the face and the body. There is acne like pimples on the face. Then alopecia, which is hair loss, baldness we call it. Infertility due to chronic anovulation. When ovum is not releasing, that means it will ultimately result in infertility. So polycystic ovarian syndrome mainly occurs as a result of accelerated gonadotropin releasing hormone pulse frequency. One thing you need to keep in mind, that the pulse frequency of at what frequency, at what rate a hormone is being released into circulation, this have a major effect on the release of hormones from the other glands. So the gonadotropin releasing hormones pulse frequency, the frequency at which gonadotropin releasing hormone releases from the hypothalamus, it is basically accelerated in case of PCOS. So when due to this altered pulse frequency of GnRH results in more production of and release of luteinizing hormone as compared to follicle stimulating hormone. So when LH, the luteinizing hormone, is being released more into the circulation, it favors the production of testosterone over testosterone from the ovaries. Okay, so more testosterone is being produced from the ovaries. Now there is high circulating levels of testosterone in the female body, which results in hirsutism, which is hairiness, hair on the face and the body, acne, and alopecia, which is baldness or loss of hair from the scalp. The high circulating levels of testosterone also prevent development of dominant follicle, resulting in an ovulation, as I already discussed. The ovum is not released. Now because dominant follicle is not developing, so multiple non-dominant follicles develop, resulting in the formation of multiple ovarian cysts. This results in oligomenorrhea, amenorrhea, or even prolonged anovulatory menses. Now coming to erectile dysfunction. Erectile dysfunction or impotence is the inability to get a penile erection or keep a penile erection firm to have a sexual intercourse. Sexual arousal increases blood flow to the penis and relaxes the cavernosal sinusoids. Relaxed cavernosal sinusoids fill up with blood, making the penis rigid, elongated, and erect. And in this erection, in this filling of the cavernosal sinusoids, nitric oxide plays a very important role. Nitric oxide, which is released from the vascular endothelium or from the parasympathetic, non-adrenergic, non-cholinergic nerves. So this nitric oxide, it results in relaxation of the corpus cavernosum. How? By generating cyclic guanosine monophosphate. This cyclic guanosine monophosphate is responsible for the relaxation of the corpus cavernosum that fills with blood during penile erection. Now, in the patients suffering from erectile dysfunction, phosphodiesterase 5, PDE5, that has been depicted here, it basically causes the destruction of cyclic GMP to 5-GMP, 5-guanosine monophosphate. So when cyclic GMP is repeatedly destructed, it is no more available to cause relaxation of the corpus cavernosum. So these sinusoids cannot be filled with blood, and therefore penile erection cannot occur. This is all about erectile dysfunction. Thank you.